Dr. Schroeder.
Thanks, Casey. And thanks everybody for coming. I'm happy to talk to you guys today about when to see a spine surgeon. So I'm going to talk about kind of three things. Okay. One that is kind of when you need to immediately see a spine surgeon. One is when you need to see a spine surgeon for your cervical pathology, which is basically for neck issues. And the last time is for lumbar pathology or kind of low back issues. I think about kind of the immediate time, and this is when I would tell you, listen, you really got to go to the emergency room. It's hard for me to evaluate you in my clinic if you're having any of these, is if you have had some kind of significant fall and you're concerned that you may have a fracture, you fall, you have significant neck pain, you really have to go to the emergency room for these. You don't want to miss any type of fracture in your spine. They can be life-threatening. And they're really hard to see sometimes on x-rays. They're much better with a CT scan and an MRI. And so oftentimes we don't have those immediately available to us in the emergency or in the clinic. So if you're in some kind of accident and you think you may have hurt something pretty significantly, that's the time you want to go to the emergency room. The other times I tell people is if you're having severe back pain, neck pain, and you're concerned that you may have an infection, how do you know about this? Right. Well, it's similar infection concerns, right? You have had a fever, you have chills, things along those lines, night sweats, and that accompanies really terrible back pain. Again, I would go to the emergency room because these can really basically only be diagnosed with a combination of lab work as well as advanced imaging like an MRI. So if you come into my clinic complaining of terrible back pain with fevers, chills, and night sweats, I'm going to tell you got to go to the ER. Last is kind of, well, not last, but second to last is what we call cauda-equina syndrome. So if any of you guys have been in my clinic, I tell almost everybody, I say, the only time from a lumbar spine surgery that you really have to have spine surgery is if you're developing really profound weakness in your lower extremities, bowel and bladder issues, or what we call saddle anesthesia, which is kind of numbness and tingling in your groin such that you can't feel yourself when you wipe. When you're having this, it's an emergency and you have to really be evaluated immediately. The other time when you really need to see an immediate referral, but it's probably not that you have to go right to the ER, is if you're having progressive neurologic deficit, meaning, right, if you feel like, hey, I have severe pain and all I've got is pain, that's okay. There are lots of things, calling your primary care physician, things like that are worth doing before you come and see a spine surgeon. But if you say, hey, I have terrible pain down my leg and I notice that I'm really struggling to move my foot, it's just not moving as well. Well, now you've got, it's not a severe neurologic deficit, but it's significant enough that you should be seen within the next week or so by a spine surgeon. So when we talk about cervical pathology, there's really two things that we talk about in the cervical spine. We talk about compression on the spinal cord, which is a diagnosis that we call cervical myelopathy, and compressive on the nerve roots, which is a diagnosis that we call cervical radiculopathy. So cervical myelopathy is a disease where there is pressure on the spinal cord. And unfortunately, the spinal cord is one of the areas in the body that really just does not heal very well, right? If you've ever known somebody who was in a car accident and they injured their leg, one of my colleagues can oftentimes fix the bone in their tibia, and they might not be perfect, but 6 months later, they're walking their dog, doing those kind of things. It's not a major issue. I hope you don't know anybody that's ever been in a car accident and injured their spinal cord. But if you do, unfortunately, sometimes despite everything that we do, people may still be paralyzed. And the reason for that is that the spinal cord is just one of the few areas in the body that does not heal very well. So when you have cervical myelopathy, you need to be seen by a spine surgeon sooner rather than later. The big thing to know about, well, how do I know if I have cervical myelopathy? Well, cervical myelopathy, it oftentimes starts kind of insidiously. You'll have some minor numbness and tingling in your hands, some minor issues with your fine motor skills. I ask people, just buttoning your shirt, writing your name, your balance may be a little bit off. It's really common for me to see patients in my office who have cervical myelopathy, and they've just attributed it to, I'm just getting older. I'm just, I'm tripping and falling a little bit more. My handwriting's changed. Is it possible that that stuff is coming from just getting older? Sure. But oftentimes there's an underlying cause of what it is. And cervical myelopathy is probably the number one cause of it. The important thing is that when we do surgery, we can stop the symptoms from getting worse. So you want to be seen when you have really mild symptoms as opposed to waiting to when these symptoms are really severe, right? And if we look at the natural history of cervical myelopathy, this has been really well established for almost 100 years now, is that when you have pressure on your spinal cord, the symptoms get worse in almost everybody. We kind of traditionally talk about them getting worse in what's called a stepwise deterioration, which means you may be here for a little bit of time. Your symptoms will be relatively stable. It may be a day, a week, a month, 6 months, and then something minor happens and now your symptoms fall down a little bit. Then they'll be stable again for a day, a week, a month, and then they fall down again. Um, and what we know, as I said before, is that spine surgery works really well to keep you where you are, but only about 2/3 to 3/4 of people get better with spine surgery. The rest of the time, we consider a success if we're stopping it from getting worse because we know this is a progressive disease. Um, Even patients with mild symptoms. So I oftentimes will have people come in and say, Doc, I really have, mild myelopathy symptoms. My hand function just not perfect. I don't want to undergo surgery. What we know is that if you wait until your symptoms are more severe, you're going to have a worse outcome, right? So we looked at about 107 of our patients that we took care of, and the MJOA is this score that looks at myelopathy. And when you have surgery, when you have mild myelopathy, at worst, a year down the road, 2 years down the road, you have mild myelopathy. If you wait until your symptoms get worse, then a year down the road, 2 years down the road, a lot of people still have moderate to severe myelopathy, and that can be really disabling. So it's scary to think, hey, I'm going to do a small surgery when I really have mild symptoms. But truthfully, it's much more scary to wait a couple of years and then have a progressive neurologic deterioration. And then those people are oftentimes very, very upset because their symptoms are now much worse. And I tell them surgery is only going to keep you where you are. There are lots of different treatments for both cervical myelopathy as well as cervical radiculopathy. You sometimes have to make an incision in the front, sometimes you have to make an incision in the back. In the cervical spine, vast majority of the time we do fusions, but there are non-fusion procedures that we can do if you are a candidate for those. It's a little bit harder to be a candidate for those. I tell everybody, right, a one-level anterior cervical discectomy and fusion, that's the surgery that Peyton Manning had. And he was able to play in the NFL afterwards. So oftentimes people are afraid, oh, I'm going to need this huge surgery and my life's never going to be the same. That's oftentimes not the case, particularly if you catch problems early. When we look at kind of cervical radiculopathy, so this is compression on the nerve root itself as opposed to the spinal cord. So this is oftentimes, rather than issues with your fine motor skills, balance, walking, kind of weakness, this is oftentimes people say, oh my gosh, I got a pinched nerve in my neck and I feel like I've got a lightning bolt going down my arm. I feel like somebody is stabbing my arm. This is a very different diagnosis. So diagnosis where the nerve is pinched, and about 80% of the time, the symptoms will get better without surgery. They don't always go away. This was kind of a long-term study similar to the ones we talked about before with myelopathy, where we know it gets worse and worse. And what they found was over years, if you have a pinched nerve in your neck, about 50% of people get completely better without any further treatment. About 30% of people will be stuck with some kind of mild symptoms if they don't have surgery. And unfortunately, 25% or 1 in 4, the symptoms will be persistent or get worse. So where myelopathy, I tell everybody, listen, you really need to have surgery. Radiculopathy, depending on the severity of your symptoms, there's a lot of things that we can do non-operatively for it. The good thing about radiculopathy is that it gets much, much better with surgery. So if you've worked with physical therapy and anti-inflammatories and you're not getting better, and we can do injections into the neck for radiculopathy. We'd never do injections for myelopathy, but we can do injections for radiculopathy. If you can try all of that to see if it gets better. If it doesn't, then the good thing is people who have surgery for radiculopathy do really fantastic. Here's kind of two of the classic studies looking at, over 100 patients apiece, and each of them had, 90+ % chance of, good or excellent results. This was a study that I published a couple of years ago looking at It was about 400 patients who either had an anterior cervical discectomy and fusion or a disc replacement in their neck. And the important thing to know is 95% of the patients were satisfied 5 years after surgery because their symptoms were better. So cervical radiculopathy oftentimes is a scary surgery. They're concerned, oh my gosh, I've got this pinched nerve, I've got terrible pain. Sometimes you have weakness down your arm. But the good news is oftentimes with a very small, minimally invasive surgery, we can make you dramatically better. Kind of the last time that you need to have surgery or to see a spine surgeon for your neck is if you really have significant deformity, right? I'm not going to spend a lot of time talking about deformities today, but there are things that we can do if you can't lift your head up, but these are really major surgeries. When we move on to the lumbar spine, we talk about lumbar disc herniations. I think that this is really important to hear for the lumbar spine, but it's also true for the neck, is that in spite of the fact that you have a disc herniation, right, we only treat them surgically if you have nerve pain. So in the neck, that's cervical radiculopathy with pain in the shoulder and down the arm. If you have a cervical disc herniation and you really have no neck pain, or you have no arm pain, and you don't have myelopathy, there's really no role for surgery. Similarly, in the lumbar spine, if you come in, and I see people all the time who I say, so what brings you in to see me today? And they tell me, oh, I've got 3 disc herniations. I say, okay, well, do you have any pain down your legs? No. Do you have any numbness, tingling, or weakness? No. I just have terrible back pain. Well, spine surgery just does not treat back pain in the vast majority of patients, right? There are occasional exceptions for people who have broken bones, who have deformities. There are significant instability, things where there are occasionally times where spine surgery will treat back pain. But in general, spine surgery is really designed to treat in the neck, pain in the arm, and in the back, pain in the butt and down the leg. Many patients have disc bulges, but if they're not pinching on a nerve, then surgery isn't right. It doesn't mean that there's not good treatment. It's just that you probably should see one of our non-operative doctors as opposed to myself, because really the best treatment for you for pain at and above the belt line is a combination of therapy, anti-inflammatories, core strengthening, weight loss. There are different kinds of injections that they can do, right? And so there's just a big understanding that everybody has some disc bulges and things along those lines. But unless there's a true herniation pinching on the nerve, it's not something we worry too much about. If you do have a disc herniation that is pinching down on your leg, assuming you don't have kind of the significant neurologic deficits that we talked about before where you're having pretty severe weakness, then oftentimes we can treat these non-operatively. About 80% of people get better from a lumbar disc herniation without surgery. And truthfully, there's nothing that we do short of surgery that changes that. All we're trying to do is buy your body time and allow your body to heal. Because if you have a disc herniation, your body will try to dissolve that disc herniation and heal it. And so our combination of therapy, medications, and injections are just designed to calm the nerve down and let your body heal it. If your body is able to heal it, then oftentimes you won't need surgery. But if your body is not able to heal it, then oftentimes people do really, really well from surgery. The big question is kind of how many injections can I have? How many injections should I have? A lot of that kind of depends on what the disc herniation looks like, but it also depends on how you're responding to the disc herniation, right? Most people who are going to respond to a injection get pretty significant relief within the first week or two, right? And it's usually with the first injection. It's pretty rare that people have kind of dramatic relief with the second injection if they didn't have 2 injections. In general, most insurance companies will pay for 3 injections in a year. In general, I tell people we just don't usually get that far. I'm happy to write you for 1 injection. If it didn't work, I oftentimes send you for a second injection. But if you've had 2 injections and neither of them have worked, the likelihood that the next 3 or 4 are going to work is pretty low. So when we talk about how do we treat these patients, right, there is really probably the highest quality evidence in all of orthopedics is from the Spine Patient Outcome and Research Trial. This was an NIH-funded multi-center study that looked at the treatment of lumbar disc herniations, as well as spinal stenosis with and without instability. And what we know is that both at 3 months as well as at 4 years, if you have a disc herniation and you have surgery, you will do better than patients who don't have surgery. So what I tell everybody is, listen, you need to give it a solid try of non-operative care. You don't want to rush off and jump to surgery for everybody because there is a chance it will get better. But if in 6 weeks it's not getting better, both in the short term and in the long term, there's really good evidence that your outcomes will be the best if we do this very small surgery. So I'm happy to see anybody who has a disc herniation and we can kind of talk about it. And the the question always becomes when they come into my office is, well, how long have you had symptoms? If you've had symptoms for 4 months or 5 months and it hasn't gotten any better, then I usually tell people, well, we should move forward with surgery. If you see me after 2 weeks, I'll oftentimes try to do things like injections, therapy, anti-inflammatories to try to get it to calm down. There is some evidence that the longer that you wait to have surgery, the less effective the surgery is. All right. I think this makes common sense, right? If your nerve is pinched really tight and you wait for 6 months to have surgery, that nerve has to heal. It's just not going to heal quite as well as it does if you have surgery within, 6 weeks, 8 weeks, things like that. Aside from disc herniations, the other thing that people talk about all the time in the lumbar spine is spinal stenosis. And what is spinal stenosis? Well, spinal stenosis is compression of the nerves, and it can be really for any reason. But the big thing is it's usually arthritic, where you have a combination of disc degeneration as well as the ligaments get thick. There can be instability, there can be cysts, things like that that are pushing on the nerves. But again, just like with disc herniations, the times when we treat these surgically is not if you have spinal stenosis on an MRI and back pain. It's when you have pain that is in the posterior buttocks, goes down your legs. Oftentimes for stenosis, this pain gets better with rest. You can have some weakness, numbness, and tingling and things like that in your legs. Again, the sport trial basically showed that after 6 weeks, if you're having pretty severe symptoms, both at 6 months through 4 years, you're going to be dramatically better if you have surgery than if you don't have surgery. One of the things that people oftentimes get very concerned when they come into my office is talking about things like lumbar fusions, right? They say, well, listen, if I have this pinched nerve going down my leg, how do I know if I need a lumbar fusion? Well, most of the time you aren't going to know that. We're going to have to get x-rays with you bending forward and bending back and see if you have any instability. Even with a lumbar fusion, the goal of the fusion is really to treat the leg pain. It's just that if the bones are sliding back and forth, we have to stabilize it or the leg pain won't be healed. There is, again, lots of evidence that the leg pain gets better with a lumbar fusion. And what I tell everybody is, right, everybody has a friend who had an incision that was like this long. And I call it, their Uncle Jimmy, who had a surgery 30 years ago. Spine surgery and lumbar fusion specifically aren't like that a lot of times now. Well, over half of the lumbar fusions that I do, I can do minimally invasively through a couple of small incisions. So it is something where we can take the pressure off the nerves and treat the leg pain. And if you come in with the leg pain, just because you hear you need to have a lumbar fusion doesn't mean it's necessarily something you need to worry significantly about. There are sometimes very small, minimally invasive surgeries that we can still do to treat this. I oftentimes have patients ask me, well, should I come in and see a spine surgeon before or after I've had an injection? From my standpoint, I'm fine with you having had injections beforehand. I'm also fine with sending you for injections, right? I think the big problem with injections is kind of understanding that for some people they work really, really well, and for some people they don't work at all. And oftentimes in stenosis, this is because it depends on how severe the pressure is on the nerves, right? If you have mild stenosis and you come in and see me, I would tell you, you have to have
Dr. Schroeder? Looks like we're having a little technical difficulty with Dr. Schroeder. while he's frozen, and hopefully we can get him back up and running. I did want to make a note that I didn't mention before. We do have a VIP line if anyone needs to schedule an appointment with Dr. Schroeder. Again, he sees patients in our King of Prussia and Willow Grove office. That number is 610-480-6584. I did write that in the chat and he got disconnected. So hopefully he jumps back on in a minute. But that number again is 610-480-6585. Oh, here he is.
I am so sorry about that. I have no idea. My internet just suddenly went down.
That's okay.
But let's see. Last thing I was saying was just that if you do have a big deformity, again, that is another reason to see a spine surgeon. But in general, what I would tell patients is it's just important to understand that there's a big difference between surgery for a deformity, which is really major, multiple hour surgeries, and kind of the other things that we've been discussing today. All right, so thank you. I'm happy to answer any questions that you guys have.
Yes, thank you, Dr. Schroeder. When you jumped off real quick, I did review a VIP line for anyone on here if they want to give you a call or give our practice a call, and we'll schedule an appointment for them. Again, you see patients in King of Prussia and Willow Grove. That number is in the chat box, 610-480-6585. Any questions you can put in the Q&A. We do only read aloud more general ones, so please don't get too specific. The first question is, what about compression fractures in your spine? What is the treatment for an acute or subacute fracture of your vertebrae? Is kyphoplasty operation a good option?
Sure. So couple of comments on that. So in general, compression fractures aren't operated surgically. Kyphoplasty is a procedure, for those of you who don't know, where it's usually an interventional radiologist, it's not a spine surgeon, who puts cement into your vertebral body if you have a compression fracture. There's two things. There's one called a vertebroplasty where they just put cement in, and one is called a kyphoplasty where they put a balloon in, try to blow it up, and then put cement in. I do have to say that the American Academy of Orthopedic Surgeons recommends against the use of kyphoplasty because there were 2 randomized controlled trials that did not show any benefit to it. Vertebroplasties, they say it is a possible option. I will personally say that I have actually, even though I don't do kyphoplasties, I've written articles arguing that they should be considered an option for patients. The 2 randomized trials were pretty poorly done and they didn't necessarily have a timing. So if you have a chronic compression fracture, I think there's no doubt that a kyphoplasty or a vertebroplasty is not going to help. If you have an acute compression fracture, in general, I tell people the vast majority of people don't need a kyphoplasty or a vertebroplasty, and I rarely recommend them. But if you are having one, I would tell you to talk with, usually it's an interventional radiologist who's doing it, and it's worth having a discussion. But it's usually only for people with acute compression fractures with really disabling pain.
Great, thank you. Next question, are you doing cases in a hospital setting or a surgery center?
I do. So personally right now I'm operating at Bryn Mawr Hospital, Abington Hospital, and Thomas Jefferson University Hospital. I have done plenty of cases in surgical centers, and as well as kind of specialty hospitals like FICARE and the Rothman Specialty Hospital. Spine surgery, I think, really limits the number of cases that we can do in ambulatory surgery centers. I think in general, it's much safer to do spine surgery at hospitals. So I recommend doing all the spine surgeries at hospitals. There are small surgeries like a micro disc that you can absolutely safely do at a surgical center. But probably 90% of the spine cases need to be done in a hospital, which makes it hard for me to take an entire day out of the week to go to one of the small places.
Great. Last question. How does osteopathic manual manipulation come into play, different from a chiro?
Sure. I mean, I think that in general, any type of manipulation, as long as it's not on your neck, I'm a little bit worried about that, I think is reasonable, right? if you have pain that is at and above the belt line, what I will tell you is that the truth of the matter is spine surgery doesn't work for pain at and above the belt line. Furthermore, I'm not overly optimistic that the injections and things like that are going to help. I think the best thing you can do is work on 20 to 30 minutes a day, 5 days a week of core strengthening exercises. That's what I personally do for myself. That's what I recommend for my wife who has significant back pain. But I do think that the difference is if you're doing that, if it's not enough, whether it's chiropractic manipulation, physical therapy manipulation, or osteopathic manipulation, I think they can all be beneficial. A little bit of it, I think, is more trial and error and seeing what helps you.
Great. Dr. Schroeder, this was wonderful. You had so much good information. So I appreciate you taking the time to be with us tonight, and everyone that joined in. Thank you so much. Again, we did record this, so I'm going to be sending it out to you probably in the next day or two. So just keep an eye out in your email for that. So everybody have a wonderful night. Thank you.
Have a nice night, everybody. Thanks for coming.
Take care.